But welcome everyone. Thank you so much for being here with us this afternoon. I'm Erin Hankey, and I'm an assistant professor of counseling at the University of Northern Iowa. Prior to becoming a faculty member, I worked for a number of years as a licensed mental health counselor. The things essential to me across the context in which I worked was the importance of creating access to quality mental health care, whether that was physicians and healthcare workers receiving care, or graduate students, or families in rural communities. And I attended a pre-con session yesterday with Dr. Gladding, and he talked a bit about happenstance. And it just so happens brought Elaine Eschba into my life. So I took a leap and went into full-time teaching. And I happen to, in my school, have a talented and skilled gerontologist in Elaine. And she's somebody who puts into action that idea of creating access. And so that's where I'm coming from today in sharing with you some of the anecdotal information that we've heard from counselors, that we've heard from staff members in care facilities about their experiences with the pandemic. And we've put our heads together in trying to be responsive throughout the pandemic with guidance, suggestions, the capacity to listen and sort through and problem solve. And we want to do better and be better moving forward as we train counselors and work to be responsive to the needs of older adult clients. So Elaine, I'll let you introduce yourself, and then I'll give us an overview and we'll dive right in.
Sure. Thank you, Erin. That was a really nice introduction. I'm a gerontologist, but backing up a little bit further, I am a nursing home brat. I grew up a nursing home brat because my mom was the activity director at a nursing home, and she was a single mom and didn't have childcare. And the residents were my best friends, and particularly the residents with dementia, because kids play with each other by stepping into each other's worlds. And I did that as a child with my friends who had dementia. And little did I know that would be the premise of really my career in terms of working with people who have dementia and allowing them to succeed and putting them in a place where they can succeed and where they can thrive. So for me, the last, year and a half now has been really interesting, really sad. It's made me think a lot, and we're going to bring some of those ideas forward for you today. So I'll go ahead and turn it back over to Erin.
So we do want to share what we've learned about nursing home residents' experiences and their loved ones' experiences over the course of the past. Is that you'll walk away with some ideas and about how to address some of the mental health concerns, maybe some thoughts on engaging in collaborative care, and joining us and us supporting you in collaborating for and advocating for a further provision of services. So when we were pulling the idea for this presentation together, here were some of our guiding questions, and they'll serve as an outline for what we'll share with you today. One is with what's adjustment like to life in the nursing home to begin with? What are some of the challenges, the strains? What enhances quality of life as people are making that adjustment or transition? What are the real day-to-day impacts that people have experienced? And then how can we conceptualize or think about, use research and theory to help us understand as well as respond to situations that adequately cared for, and here we are with this need in front of us. So this is where we will get started, and I'll turn it over to you, Elaine, to talk to us about adjustment to life in the nursing home.
Yeah, absolutely. So I really work in two worlds that seem very different, but in many ways they aren't all that different because they both deal with a lot of transition. So I work with college students who are leaving home for the first time and moving into the residence halls or maybe apartments. I work with older adults, and many times those older adults are also moving, and they may be moving into assisted living, nursing home, memory care communities, or even in with their children. So there's a lot of transition involved with both of these groups. But one thing that I find unfortunate is that whereas we have become very committed to transitioning young people from being with their parents to college life, we have not done the same thing with our older adults who are transitioning. So right now, at our university, I remember, not to date myself, but I started college in 1996. And, orientation, I went up, I think I spent one night, and you got to stay in the dorm and play games and meet people. And then you moved up the weekend before classes started. Well, that's still more orientation than you receive when you move, say, to a nursing home. But now we have a lot more than that going on. We have students who have the ability to move to campus and improve their adjustment by, coming a week, or in some cases, even 2 weeks, or spending time during the summer. So we know that student success and student retention is really strongly related to those first few weeks, that first month of college life. So if college students have a good experience in that transition, they are much more likely to stick around. So we as universities have started to invest in that. However, when it comes to older adults making that transition into nursing homes, I don't see that at all. So for most nursing homes, we take someone there, we take a few of their belongings, and then the family gets very upset when the person is experiencing any type of emotions, whether it is anger, resentment, sadness. The family doesn't understand why the transition isn't going more smoothly. But that move represents a lot of loss. It represents a loss of home, a loss of one's neighborhood, a loss of, in most cases, time with family and friends. Really importantly, it involves an extreme loss of privacy. So to be honest, there's really not that much research out there on transitioning into a nursing home. So, we know that those who feel as if they have a greater sense of autonomy or more control tend to adjust more positively. So if someone is involved in that decision making, rather than feeling like they have just been jammed into this decision, we know that they do better. We also know that 70% of nursing home admittances are done in crisis. And we know that the other 30%, which involve what I would call nursing home shopping and involve planning, the residents in those tend to have better adjustment, and they tend to see less of a decline in physical health. So some things that we do know about nursing home adjustment and the quality of life. There's very strong research that shows the quality of life and also the initial adjustment can be improved greatly by access to outdoor areas. So this goes back to nursing home design and restorative environments. So if there is a way for a nursing home, first of all, to have a lot of natural light, but also to have some sort of courtyard access where there does not have to be extreme supervision. So someone does feel a sense of autonomy, that can be very important. In addition, not surprisingly, family involvement is related to quality of life in the nursing home and adjustment. So we know there are some things that can improve that transition and can generally improve quality of life in that nursing home. And this is challenging. I don't care when we're talking about, okay? This is really challenging. Moving to a nursing home, it not only represents the loss due to the move, but if you think about what that move is usually precipitated by, there's usually loss involved in that. Well, my husband died, so now I'm moving to a nursing home. Or there's a loss of health, and that's why you're moving to a nursing home. Or a loss of a caregiver. So whatever it may be, it's usually rooted in loss even before you move to that nursing home. Can you flip me to the next slide, please, Erin? So how has COVID-19 impacted residents? And I don't even know where to begin here, but we know that the feeling of having a little bit of control is really important for nursing home residents, and any sense of autonomy that they felt they had was lost. So the loss of decision-making power, the loss of choice, the loss of the ability to decide, oh, do I want to have my meal delivered to my room? Or do I want to go down to the dining center? Do I want to do an activity today? Or do I want to just sit outside in the courtyard? So the decisions that residents usually do get to make, which aren't all that many, were not available to them anyway during COVID. We talk a lot about loss of family visits, and that's really, really important. And if you, during COVID, listen to anything on the news, that was the first thing they talked about, are these poor nursing home residents don't get to see their families anymore. Yeah, that's difficult. That's hard. And I understand that, but I think we're missing a lot when we just focus on that. So I had one woman tell me, actually, she told her a friend this who told me this, but she said, to be honest, she said, I didn't really miss my family that much because they only came to visit once a week, but she had a lot of friends in the nursing home that she got to see every day. And that void for her was actually more difficult than the family because it was more constant. So keeping in mind, friendships develop in nursing homes. Many times people who live in nursing homes, especially in small towns, might have someone down the hall that they went to kindergarten with, and that person is someone that they can no longer have contact with. And sometimes I think it makes it even more difficult knowing that they're so close and not being able to have contact with them. So no group meals, no activities. And in many situations, we have residents who are very news savvy. They follow the news, and during this time, what did they do? They turned on the TV in their room, because what else are you gonna do when you are in your room 24/7 except watch TV? And you see the death tolls of people dying from COVID and talking about nursing homes and how rampant it is in nursing homes. And that's very traumatic. I have had nursing home residents say to some of my students who are interns and work in buildings, this is like prison. A lot of times people would say, I'd rather be dead. I would rather be dead than do this. But, I thought about this, about how, we say it's like prison, and, what is the worst punishment as a society we give people? There's the death penalty, and then there's solitary confinement. So, this is the life these individuals are living. Sometimes having a roommate is better during this time. Sometimes having a roommate is not better. It's going to depend on your roommate. And again, even if you have a good relationship with that roommate, I'll be honest, I struggled being in this house, and we have like a, 2,000 square foot house. I struggled being in this house just with my husband. I can't imagine being in a small room with him and not being able to leave that room. So sometimes it was feeling very lonely and isolated, but also feeling very suffocated because of that one other person. Your roommate may or may not have the cognitive ability to carry on a conversation. I do want to touch, because dementia is my area, on masks. Masks are really anxiety provoking for people who have dementia for a lot of reasons. One, because it's harder to recognize someone with a mask on. And we all know that because, we started seeing our friends and colleagues wear masks, and we had to kind of give them this look, and then a year and a half later, they took them off, and then again, we did the same look again, like, oh yeah, there you are. But for people with dementia, it's really hard to recognize someone, even if it's someone they see every day, wearing that mask. Your family may not be there, as a person with dementia. These are the people who are familiar to you, but they're not familiar to you anymore. There's an issue with communication as well. And this is true for many, many nursing home residents, especially those with dementia, those with hearing loss as well, who rely a lot on not just reading lips, but also facial expression. So with dementia, we say that, long after people are unable to decipher words and to decipher sentences, they're able to decipher your facial expression. Well, they no longer had that. So people with masks, are they smiling? No, you can't see a smile. It's not comforting. And another thing to keep in mind is generally with masks, when people before COVID were wearing masks, um, you weren't in a good situation. You were at the dentist, you were about to have surgery, you were being robbed. So if you're an individual who doesn't understand why everyone around you is wearing a mask, that is incredibly traumatic. And I think we've kind of missed that. So when we look at this nursing home population, it's difficult to be that resident who understands everything that is going on and watching TV, and having that anxiety stem from seeing what's happening in the world. But then you have the resident who really doesn't understand any of that. And that's a terrifying space to be in as well. Loss of access to outdoor space is a big one. I had a lot of students who work in nursing homes tell me that their residents were begging them, like, just take me outside for 20 minutes. I just need to be outside for 20 minutes. And this is a population where many of them may not get a lot of outdoor time, in the first place, but reducing that to zero. A lot of residents started to show signs of aggression, due to the trauma that they were experiencing. There's a lot of trauma and anxiety just being in a space that is plagued by illness and by death. Okay. You hear things like so-and-so got taken to the COVID wing. Well, that's someone you know. How sick are they? Are they coming back? Are they going to die? Sometimes, in most cases, because of HIPAA, nursing home staff should really not be telling you these things. So they should not be able to tell you who has COVID, who is ill, who went to the hospital. So many of those things are left to your own imagination of what's going on just in the area, right around you. In addition, one of the things that I really have struggled with as a gerontologist during this time is just this, well, it only affects old people. Only old people die from this. And this is a message that didn't stay out of nursing homes. People in nursing homes understood that this is kind of the way society was thinking. And many of them started thinking the same way, to be honest, in terms of, well, what if I die from it? So what? My life doesn't have any meaning anyway. And at that point in time, it really did feel that way, because when you can't leave your room and you are struggling to connect with family for many reasons, first of all, phones work for some people, but a lot of residents have issues with phones due to hearing issues, cognitive issues. We have things like FaceTime, we have things like Zoom, and it's fantastic if a resident is comfortable using it. Some residents, that might actually cause a little bit more anxiety, not really understanding what that is. And also, it takes some staff time to get that up and rolling. And many times staff just didn't have that time. You want to throw me that next slide, Erin? I also wanted to talk about reunification. And this is what I'm really struggling with. And, there's a reason why a lot of this conference is virtual. I would perhaps, really right now, love to be in Charlotte with all of you. But, we're in a space right now where things are still pretty ambiguous. Nevertheless, we still have a lot of people saying, we made it. We made it through COVID. And I remember hearing that a lot a few months ago. And I have an issue with it because, first of all, not all of us did make it. Okay, when we say we made it, well, some of us did and some of us didn't. But those in nursing homes who did make it, and I'm not even going to go into the separation of nursing home residents and their families at the time of death. I have many my gerontology students during this time, complete rock stars. Many of them were the people, pulling out their cameras or bringing their iPads so that someone could see their loved one die. I will tell you, my gerontology students learned more the past, year and a half than I could ever in a million years, teach them. So when we talk about, this being over, no, we didn't all make it through this. And even those of us who did, and I'm not just talking about nursing home residents here, and they may be an extreme case, but we are all different after COVID. We're not really the same people we were before. So residents with dementia may not remember family members when there was finally a reunification. And most people I talked to were so excited to connect with their loved one, right? So excited to connect with their loved one who's a resident in a nursing home, haven't seen them in this time. And many times people were telling me that, they kind of expected this Lifetime movie type of reunion moment, and it was anything but. So not being recognized, residents having a level of resentment toward them. In addition, we have seen a lot of physical changes in residents. So in over a year, it is likely, almost every nursing home resident is going to have some type of physical or health change, right? That's not unusual, but you have to think about what happened in this year. So loss of physical therapy or limited physical therapy, loss of other types of therapies as well. The other thing is just loss of opportunity to be active. So residents who get up and they walk their laps around the nursing home, or even if they're in a wheelchair and they move their feet and they walk about the nursing home, they were unable to do that for so long. So we're talking about changes that occur due to this lack of activity. So less muscle tone. In addition, a friend of mine said they finally saw her grandma, and it was a shock for a few reasons, but one was just that there had not been a beauty shop operating in the building for so long, and her grandma's hair had always been short and it was really long and shaggy. And so it was a visual reminder that her grandma really was a different person than she was a year ago. So the reunion stuff has tended to be a little bit more unfulfilling for families. It wasn't all happy like we expected, and it was kind of meh. And again, we're in this ambiguous place because I know so many nursing homes, even in our area, that have been open. You can go in for a visit. We are ready to go. And then you have a nurse or a CNA who tests positive for COVID, and you take 2 steps back. So, it has not been, in terms of visitation, this, steady progression of, taking off these limitations, more and more freedom in visitation. It's kind of gone like this. And that's been incredibly frustrating, both for families and for residents. And the best advice I give, because I know a lot of families are, again, struggling, where do we go from here? And, the only thing I can say is we can't go backwards. So you need to accept and you need to love the person in the moment. Are they going to get these gains back? All the things they lost, are they going to get the gains and go back to the way they were before? No, they're not. Okay. And your job is to love them where they're at. And also remember that as a family and as an individual, you are different after COVID as well. So I'm going to go ahead and turn this over to Erin to kind of summarize this and kind of talk about how we can put ourselves in positions to be really helpful.
As we shift over, are there questions from folks or comments as you're listening? That's a lot in a short amount of time. David, go for it. And I think John has us muted on this computer. That you're.
There we go.
Can you hear us now?
Yes.
Yes.
Hi.
Yes. Hello.
Hooray, interaction, right? Yeah, I was just going to make a comment that I've been personally living through this experience with my mother, who's been living down in Atlanta. She was transferred to an assisted living facility right before COVID really kicked off. And so it was about almost 2 years since I had been able to see her when I went to visit her in May. And a lot of the things that you were talking about were definitely things that she experienced. So I spent a week taking her out of the facility, driving her around, taking her to parks, going on little shopping errands and things like that. And even then, they had just opened up the facility, and you know, I had to show my vaccination card and things like that. But I certainly saw a lot of the dynamics that you're describing there in that facility.
What's really interesting to me about that, to go on a little bit of a side tangent, forgive me, Aaron, is that you are asked to show your vaccination card. However, at least in Iowa, we cannot require nursing home staff to be vaccinated. So we have had a real problem getting our nursing home employees to be vaccinated here. And one of the ways they have done it is to offer them $50, $100, a gift card to a restaurant to get them vaccinated. And I find that really, really fascinating, because these are the same people who cared for residents who died from COVID. So I just find that a really interesting, a really kind of interesting conundrum that you were being asked to show your card.
Mm-hmm.
We've also had this conversation too, in terms of what the residents are able to choose in terms of who sees them and what type of care they receive. And so that's been really complicated. And David, I appreciate you lifting up the personal story, because
Absolutely.
One of the things that we've discovered is we're all living through this as we're also doing professional practice. And so that's been a really interesting tension and challenge, where we've had students who have with older adults, and so this is brand new to them. And then we've had students who are counselors in training, who are staff members in training or administrators in training, and they have loved ones too. Their parents are experiencing dementia, their grandparents. And what does it mean to show up at work in a space where this is not a context we can escape? And so part of it has been really role in supervision, as well as that collaboration of, we take the time to say, okay, let's check in on this personal level, the stories, the family, how are the different family members, how are you holding up with the decisions you've had to make this week? And then almost having a transition into, now here's the professional discussion, but there's been a lot of overlap. And we heard that in panel discussions this spring, Elaine, but the impact is enormous, and people have said, where do we even begin? And my bottom line is listening and showing up in relationships, as we all have been trained in our helping roles. That's a really important starting point. And then no matter what loss you address or what sort of connection you try to make, your presence matters. And each step you take towards something is a path. And if where you'd hoped it would be, there are dozens of other points of entry into this. But I tell counselors each time we have these conversations of, if it's a stress or a strain related to autonomy, how do we help our clients have some small modicum of choice? If it is the isolation, the confinement that's been happening, one of the things that we hear people talking about is this notion of, oh, their behaviors have increased, their problematic behaviors. Steps back and look at that context and think about, what are people able to express and what are they not able to express, and how might behaviors be an absolutely normal reaction to a really stressful, traumatic, and abnormal set of circumstances. And so the other thing that we've done, like most of you probably, is to try to figure out, what does research and what does practice teach us about? And so how can we respond? So this is where Elaine and I get into this. And part of this is where we are, and across the country, we have really significant deficits in terms of care and people trained to work with older adults. So we've been having this debate for a while now of, how do residents even become clients? And this is a really significant point of advocacy. you all in your own practices can probably have stories about how do residents become clients. For us, my default lens as a counselor educator, I'm like, what opportunities do we have for collaboration between our training program and our nursing homes in the area? What opportunities do we have in terms of adult day programming and what we can do on the counseling level at but Elaine has been instrumental in also connecting to local resources, also looking for COVID related initiatives or funding that are available and being willing to think creatively about how we can write small grants or get on the radar our older adults. And then another entry point in has been the personal and professional experiences. So maybe is that you have your aunt or a partner or a sibling living in residential care, and you've seen the needs because you've made that connection point. So what we've been talking to people about is capitalizing on those personal and professional connections in order to get us into places where we can be of service and really meet a significant. If other people have had partnerships that have worked, we are super curious about that piece. But just even that transition from resident to client, we have significant mental health needs and not a lot of folks able or having access to provide those. Elaine, you can correct me on this. One study that I read suggested that 27% of nursing home residents enter the facility having a mental health concern. So if we think about that, and a lot of times people might be placed in or convinced to go into residential care because there are not ways to address multiple complicating concerns. And so it's like, put them here in the nursing home. And so the needs were great before COVID, and now we've just exacerbated that. So I will have, but I'll just highlight a few things. So in looking at what we can do, how counselors can be responsive, is looking at things through the context of loss, looking at things through the context of grief, as well as coping, and then resilience. And so when I think about how do I enter a space, or how do I even begin to start to make an impact, I think about losses. And I know that the internet connection is now like unstable. So the multiple and compounding losses are what I think about. And part of the challenge is that a lot of times those losses are either unacknowledged. So, hey, your roommate has now been taken to whatever the COVID wing is, or has been hospitalized. Hey, you're not able to sit with your table mates when you're eating on a day in and day out basis. Those losses oftentimes go unacknowledged. Like, hey, they weren't direct family members. Yes, and these human beings shared a living space. Or yes, these human beings ate together each day in part of a routine. So just being aware of and acknowledging those losses can be really important. The other thing I hinted at it with the behaviors and saying, oh, there's something pathological about acting up or acting out, or we're automatically, if we see feelings that are big, if we see feelings that are negative, then we must race to diagnosis in terms of depression or anxiety. And those can absolutely be a part of the picture for our clients. At the same time, how can we sift through what are these loss reactions? Some pieces there. First and foremost, being able to name the losses is essential. With us as counselors, to be able to acknowledge and say, hey, this is a loss for you. And to have feelings validated can be pretty powerful. Creating spaces and opportunities to grieve. We also talk about kind of dialectic thinking, or being able to hold dichotomies. And what I mean by that is that folks with for instance, somebody who is experiencing dementia and the family now reunites. And so mom is there and not there at the same time. And so what we talk about is, how do you hold both of those realities, that mom is physically here and there's a psychological connection, but there's also a renegotiation of what the relationship is on both, because the cognitive decline has impacted how mom can be in a space or in relation. And so we think about that in terms of caregivers, but that can also be really powerful in terms of residents too, in how they see themselves and how they navigate. So how do we hold that dichotomy and help with ambiguity? I realize I have way more slides than what we're going to have time for. I'm going to hit a couple more points and then just, there any questions. That disenfranchised grief is a huge piece, and we think about disenfranchised grief being not acknowledged socially, not mourned publicly, not connected in some ways. And so how do we again create that space? What does acceptance look like? Again, it's living with the realities of the change. And sometimes what we find is that we need to help people to express themselves. And Elaine has some experience in this as well, but arts and craft supplies, opportunities to paint, opportunities to listen to music, simply being present in a space can be really important. And we try to get the counselors to be thinking, what does it mean to help somebody and to connect in a way that may not be the stories that you hear from other clients? Elaine, do you have comments on that one?
No, I mean, I totally obviously agree with you. We did start in the spring of 2020 what we called the Northern Iowa Nursing Home Art Box Project, where we collected like art supplies and we sent them to nursing homes. And there were only really two qualifications of what we would send. The first is that it was intended to go to a person in a person's room and not be used for group activities. And it needed to be something that the staff didn't have to set up or assist a resident with, that they could just say, this would be a good fit for this person. And we ended up serving over 100 nursing homes by sending them this just giant box. And it was really interesting because we got a very positive response that no one had ever sent anything like that or donated anything like that, before. And it made me realize that most activities in nursing homes are those group activities. And even in, a little off topic, Erin, but even in times, non-COVID times, people should have the autonomy to, I would like to go to a group activity and do stuff with other people, or I would like to do something alone today in my room. So in terms of just losing that autonomy, we were able to give a little bit of it back. And I'm hoping that some of the things we've discovered during COVID and through this process, we will be able to continue to implement to improve nursing home life moving forward. And that, from a gerontologist perspective, that's really one of my goals.
We've even seen in some of the research where folks are using more experiential techniques where, you don't have to be skilled in any sort of artistic form, but even drawing next to or paint as they are drawing or painting can open up opportunities to communicate or to be present in the moment. And so we're trying to think about, how do we forge those connection points? And then for residents who are able, there's been a lot of restrictions, and that giving back, that social interest, for those of you who might be Adlerian, that altruism, how do we help people to be able to give back? And fared the best are those that have been able to care for other people nearby or feel like they're making contributions to the community, whatever that community construct is for folks. So I'm looking down. We saw a lot of uncertainty, distress, which is just really helping people and understanding safety seeking behaviors. People are not trying to be annoying. People are not trying to exacerbate the situation, but they might need reassurance. They might be asking for information. They might need some extra space and pacing in terms of managing, simply because what they have experienced. And one of the things that we're headed toward is then, how do we, now that folks have been experiencing this, what does trauma-informed care look like in residential care, and how do we help our counselors to be processes? And I am sensitive to time, so questions or comments that folks have?
Hi, I just had okay, I'll show my face because sometimes that's a little odd. Hello. I was just curious with the information, because I mean, to me, this is like a personal thing. I don't usually work with older adults unless I'm working with multi-generational families, because a lot of the grandparents also like live with the kids. But I have had a lot of experience more with the Hispanic and Latinx older adults, and also their experiences in residential care, and the lack of bilingual residential staff, but also counselors. So there's a lot of layers, but this sense of isolation within self and cultural identity, and then also in residential care there. So like even having this COVID experience. So there's just been so many layers, and I know that's a lot, and it's still all very new, even with adding the pandemic, but I know that has always been a situation like in assisted living. But is there anything that you all have been able to see when it comes to maybe a diverse background within demographics, or is this predominantly like older white individuals that you've been able to see? And what are kind of what have you all been able to see, and within the identities of these individuals there?
So that is an awesome question. So a few things that come to mind. I do know a woman who is Spanish speaking and lives at a nursing home in our area. And there are Spanish speaking CNAs, but the way it got set up during COVID, it's not like you don't get rotating CNAs. They want to keep you with the same one in case there's an outbreak, right? So if you're a CNA, you're only working with these residents in this wing. Well, the nursing home did not have enough forethought to make sure that she was paired with someone who could understand her. And that was really terrifying for her. And there may have been other reasons that just didn't work. I don't know. But, she always knew that, this CNA would be working this day. So if there's anything she was concerned about, she could tell them. Well, that didn't happen anymore. Other things that are related to loss of identity during COVID that nursing homes struggle with anyway, religious diversity. So, you may, because of, being confined to your room, you may have been unable to practice your religion in the way that you would normally choose to practice your religion. And I don't know how much empathy you had from other people unless your religion happened to be a Christian religion. So loss of those religious practices, and loss of someone who has a shared language is a really, really big one there as well, especially during COVID, but at any time.
And what they're talking about is the proliferation of trauma on multiple and trying to figure, again, it's just added layers. I think, Chanel, you spoke really well to that, because that is also what we're seeing. Ways of coping, ways of practicing, ways of understanding the world, capacity to tolerate ambiguity, faith-based connections. Those are all sources of loss that we're seeing that are compounded when you're in predominantly white institutions, white, not paying attention. And so, yes, I think that we are going to see a lot more ongoing, prolonged challenges, and also setbacks because of what this has done to people in terms of their humanity. And I don't have an easy answer. And you're bringing up a really important and significant concern that, as Elaine said, we're seeing it, and have not, the response has not paralleled the concern. Do others have others seen successful responses? But that CNA piece was so essential of like, why are you making these pairings, and being intentional in the connections, and being completely unaware of why the connections were being made.
I have a question that's not related to that particular topic. Once all of the COVID restrictions are lifted, and I know it in some places they are now, but I've worked in nursing homes pre-COVID and then some post-COVID. And one of the biggest challenges was privacy. Any suggestions on how to get around that? Because if somebody has a roommate and you try to go find a place in a hallway or something, it's just really, really, really hard. And then I'm also curious to know your thoughts on trying to do any kind of group work in nursing homes.
That's the part of the challenge, and with HIPAA restrictions, and again, whose rights are prioritized with things. And we've been talking about different ways to advocate for what would it mean to have to have your neighbors hear about you in the residential care facility. What does it mean? I know in some facilities to create a private space, and what does that mean in terms of allowing people, whether that's meditation, whether that's, hey, I just need a timeout from the noise of the television, or what does that mean in terms of comfort and creating home-like pieces? And so that's been a really significant thing as well with that privacy. One, it's like, hey, if I lived next door to you and you were to go to the hospital, I would be checking in on you and your family members, but somebody shares an actual living space with me and they can't hear about what's happening. Elaine talks about a resident who read the paper just to see the obituaries, to see who in the care facility might have passed away. And again, talking about that's another way that that we've done so. Not intentionally in that manner, but that's another thing that we're wrestling with in terms of advocacy. We'll share the slides, our contact information. We'd love to hear ideas.